My name is Yazan Masannat. I'm one of the consultants in Oncoplastic breast surgery based in Aberdeen, northeast of Scotland. We're going to talk about DCIS or ductal carcinoma in situ. I'll be using some illustrations and some information from the patient information leaflets provided by Breast Cancer Care, Breast Cancer Now, and the Macmillan website. First of all, what is DCIS? DCIS is an early form of breast cancer. In the UK, about 12% of all new breast cancer diagnoses is DCIS. You might have heard the terms pre-invasive, non-invasive, intraductal, or stage 0 breast cancer, and those are all terms used to describe DCIS. The breast is made of ducts and lobules. The lobules are the glands where the milk is made, and the ducts is just little tubes that connect the glands to the nipple. And that's where DCIS starts, in those little tubes. The ducts are usually lined by one line of normal cells, and what happens is that when you have some abnormal cells inside the ducts, that's when you have DCIS. So the cells are cancerous, but they're all contained within the duct. When they start invading through the tissue, that's when you have invasive carcinoma. So why do we need to treat DCIS? It's mainly for two reasons. The first reason, if it's left, some of it might change to invasive disease over years or months. We don't know which patients will change from DCIS to invasive disease. We know that the high-grade DCIS is more likely to change to invasive disease and more likely to be a higher grade tumor, while the low-grade DCIS is less likely to change to invasive disease, and if it changes, it's usually a low-grade tumor. When we have the biopsies and we have the diagnosis, the biopsy only is representative of small parts of the bigger abnormality, and when you excise the area, you might find that parts of it has already progressed to invasive disease, and that's another important reason to take that area out. So what are the symptoms? Most patients are asymptomatic. The commonest presentation is through screening, where we find usually some microcalcifications that look abnormal, and the biopsy confirms DCIS. Keep in mind that the majority of microcalcifications are completely innocent and benign, and it's the radiologist that will pick which are the abnormal ones that needs further investigations and biopsies. Very rarely patients can present with lumps or present with abnormal nipple discharge, but that's not the usual scenario. So how do we treat DCIS? The mainstay of treatment is still surgery. If you have a small area of DCIS involving small part of the breast, you'll have a lumpectomy. If you have a large area of DCIS in relation to the breast size, or if you have multiple areas of DCIS in different parts of the breast, then most likely you need a mastectomy plus minus reconstruction. In some centers, if there is more than one area of DCIS but still can be excised surgically with a big lumpectomy or certain techniques like mammoplasty techniques, then that can be offered. What about the lymph glands? If you have a lumpectomy, you do not need to have any of the lymph glands taken out. But if you have a mastectomy, or if on diagnosis there is high suspicion that there's associated invasive disease, then the surgeon might advise you to have a sentinel node biopsy or to take some of the lymph glands out. What about further treatments? If it's pure DCIS, you do not need any chemotherapy. If you had a lumpectomy, most likely you will need radiotherapy. In certain patients where you have a small area of low-grade tumor, some oncologists will not give radiotherapy. It depends on local practices. If you have a mastectomy, you will not need any radiotherapy. What about endocrine treatment and hormonal treatment? There's lots of controversy about that, and there is lots of variation in practice about that. In the UK, we do not tend to give any endocrine treatment for DCIS, even if it's estrogen receptor positive DCIS, because the trials here in the UK did not show any benefit, while in the States and in Europe, this is standard practice to give tamoxifen or endocrine treatment to DCIS patients if they are estrogen receptor positive. Follow-up after your surgery and treatment for DCIS does depend on your local protocols. Here we do tend to see the patients in the first few years and have mammograms for 10 years. In some places they'll have yearly mammograms up to 5 years, and in some places they'll have more frequent mammograms. So you'll be guided by your local surgical team. Thank you for listening to this video. Please find on the screen a list of some websites that we find very useful for breast cancer patients. Thank you.